chapter 13 and pick up where we left off. We had just finished discussing, all right, the second region of our brain, the diencephalon, which brings us to our first clinical view here of the day. And we're going to talk about some brain disorders. All right, a couple conditions: headache, cerebral palsy, and encephalitis. Headache can be a disorder, but sometimes we'll use it as a symptom. In some cases, causes for headaches vary. It could be a tumor, it could be blood pressure issues, right? It could be, for the example that we're using here, right, when we're talking about headache pain, if the blood vessels in your skull happen to vasodilate, that means they increase, all right, in their the lumen's diameter, increasing blood flow. It can cause headache pain. And then also, some of you may have experienced what you call a tension headache. Well, that is when you can have muscles that are contracting when they shouldn't be contracting and causing a tension-like discomfort. So that's another cause. Now, migraine headaches are a whole different animal, right? Several different types of causes for migraine headaches. Some can be hormone-related. Some causes can be stress. Certain triggers include, like drinking wine or chocolate, they can trigger a migraine headache. A migraine headache is when you take a headache to the extreme level, right? Very severe symptoms, right? Often we'll see it to one side of the head, or you can have it like this hardcore, intense pain right behind the eye, right? So migraine headaches will be different than the normal headaches, but keep in mind, headache is a very broad term, and we like to use it more so talking about symptoms rather than talking about it being an actual brain disorder. Cerebral palsy, that's a neuromuscular skeletal disorder. There are several different types of cerebral palsy, right? But what we'll see is, all right, damage to the brain to the infant during pregnancy or while mother is giving birth, or it can happen right after birth. It's very close to infancy there, in which we'll see, it depends on how badly damaged, all right, obviously the nervous tissue has become, will determine the effects that the patient can have. Right? We'll see it from causing issues with walking, for example, because of what it does to the skeletal muscle system, right? To the point where it actually impairs, right, the intelligence level there. Encephalitis, keep in mind, this term ends with these last four letters, itis. And itis is an irritation, usually an acute inflammatory condition that occurs to, in this case, since we're talking about encephalitis, it's going to occur to the brain. Some sort of infection causes this. Normally, it'll be a viral infection, and depending on the severity of it, will determine the type of symptoms that the person will complain of. Right, fever, because of course, with most infections, you'll get a little bit of a fever there, right? Followed by headaches, tiredness. The patient will complain of drowsiness. If it gets pretty severe, that patient could fall into a coma. And if it gets really, really severe, that patient can eventually die. Huntington disease and Parkinson's disease, right? These diseases, right? The Huntington disease is something that a lot of research has come out in the past several years in regards to the treatment of this condition. Unfortunately, it is a genetic disease, so it will get passed down amongst family members here. It will affect the cerebral nuclei, and in case you're forgot what the cerebral nuclei are, it could be any of those clusters of cell bodies, right, within the cerebral hemispheres there. Now, if you've ever seen, I always think of, if you've ever seen the comedy, the show Seinfeld, one of the characters on there, Elaine Bettis, has this tendency to have this really awkward dance. I'm telling you, if you were to Google Seinfeld, Elaine, and dance, you'll see exactly what I'm talking about. It is this herky-jerky kind of really odd motion it looks like these people can't control their body movements here. Now, usually what we'll see is that this disease its onset will occur usually in the 20s, all right? But the later that the onset occurs, the more fatal it can be. Now, once you're diagnosed with it, all right, it's essentially, and I hate to say this, it's a death sentence, all right? And it can occur anywhere between all right, 10 to 20 years. All right, Parkinson's, we've talked about a lot in not in this class, right, but in the media for a number of years, especially when certain movie stars like Michael J. Fox have gotten it. Right? In Parkinson's disease, what we see is the substantia nigra, which we'll talk about when we get into the brainstem here, all right, has decreased the amount of dopamine that it's producing. Dopamine, all right, is used as a neurotransmitter, but it helps with movement, it helps with pleasure, it helps with fear, all right, sensations and whatnot. But the substantia nigra decreases its dopamine output. And what we'll see is it'll affect motor movements. Specifically, we'll see voluntary motor movements affected. You'll see these patients just kind of standing around and their hand might be shaking. We call that a resting tremor. But Parkinson's will affect, all right, muscle movements and overall balance. A good way to test for Parkinson's is when you have somebody just sit down on a bench, let's say, with no back to it. And you tell them to lean back into you. Just lean back into me. I'll hold you up. No problem. No problem. And then you step away really fast. Okay. Obviously, you don't let them fall to the floor. But the normal response is if you're leaning back and then that person that's supporting you steps away, your arms and legs will shoot forward, right, to try to keep you from falling back. Well, people with Parkinson's won't be able to do that. All right, you heard me mention the brainstem here, and so let's talk about it. This is the third region of your brain, and it is awesome because it connects the other three regions to the spinal cord. Right, so the cerebrum, the diencephalon, and the cerebellum will all connect to the spinal cord through the brainstem. And so in the brainstem, we have a series of tracts. In case you don't remember what a tract is a bundle of axons, excuse me, in the central nervous system. So when we talk about ascending and descending tracts, that's another way for us to say, all right, sensory and motor tracts. All right, so get rid of that. So our ascending tracts are going to carry sensory input from the periphery up to the central nervous system, up to your brain. So they're going to ascend up the spinal cord and ascend up into the brain. The descending tracts are going to carry motor output down from your brain and out to your body. So we call those descending tracts. Those are the motor tracts. Also in our brainstem, we're going to see the nuclei from several of our autonomic nervous system centers there. The nuclei for our cranial nerves, those are nerves that come off of the brain. And then we'll see some of our reflex centers, in which we'll get into a little bit of a discussion here in a little bit. All right, so there's three parts to our brainstem: the midbrain, the pons, and the medulla oblongata. The medulla oblongata. Here's a nice anterior view of our brainstem, and you can see the diencephalon, specifically the thalamus here, sits on top like an ice cream cone. Here's the ice cream and here's the cone. Now you can see distinctly, because we've color coordinated it, all right, the three regions here of your brainstem. On top is the midbrain, the pons is in the middle, the medulla oblongata here is inferior, and then the spinal cord will be an extension, and it'll extend inferiorly off of the medulla oblongata there. You'll notice that there's several nerves coming off the brainstem. These are some of our cranial nerves here. Now, if we turn things to the back and side here from the posterior lateral view of our brainstem, we can see it quite differently. So we're going to go through and talk about a lot of these structures here. All right, so don't worry. It might be a little bit overwhelming when you're looking at it, but we're going to roll through all of them. So let's start off with the top portion of our brainstem, the midbrain. All right, so a couple structures there. Let's start off with the most superior portion there, the cerebral peduncles. I'll show you a quick picture here. Here you can see it from the lateral, posterior lateral view. Here you can see the cerebral peduncle here from the anterior view. And these contain motor tracts, what we call the pyramidal tracts. Right. Basically, they're going to carry the voluntary motor information from the superior portion in the cerebral cortex, the primary motor cortex, all the way down towards the spinal cord. So keep in mind that if it's carrying what we call voluntary motor commands, that means that these tracts, these motor tracts, are going to control and affect skeletal muscle. That's the only type of muscle tissue that's voluntary, is skeletal muscle. So the cerebral peduncles will carry those motor tracts from the primary motor cortex down towards the spinal cord to affect skeletal muscle. That's the effector organ that we're going to be discussing when we talk about these motor tracts. We'll talk about that in chapter 14. All right, then we have another set of peduncles called the superior cerebellar peduncles. Notice the difference. There's the cerebral peduncles, and then there's the cerebellar peduncles. Well, the cerebellar peduncles connect the cerebellum to the midbrain. Each part of our brainstem has its own set of cerebellar peduncles that will connect that area of the brainstem to the cerebellum. So the pons has its own, and the medulla oblongata has its own set of cerebellar peduncles. So the midbrain's on top, so that's the superior cerebellar peduncle. Now, the next structure is the medial lemniscus. Again, I'll go into more detail about what this is in chapter 14, but for right now, okay, it's going to be a specific area that runs through all the parts of the brainstem. The medial lemniscus is made up of ascending tracts. Well, what's an ascending tract? It's a sensory tract. Right? It's myelinated, so it's going to have the appearance of white matter. So it'll be tough to see in certain cuts or cross sections of the brainstem because it's myelinated, so it almost blends in with some of the other myelinated regions of the brainstem. But not to worry, I'll point out some of these areas for you, right? So the medial lemniscus is going to carry our sensory information from the brainstem up towards the cerebrum there. So if we take, well, I'll show you a picture in here in a second. All right. Then the next structure, the substantia nigra, I talked about this when we were doing our clinical view of Parkinson's, right? The substantia nigra is this area in our midbrain that has this dark appearance, and that's because we have melanin there in that region. And this structure is going to produce our dopamine. All right, I mentioned this before when I was talking about Parkinson's, that dopamine is a neurotransmitter. Right? We see it involved in movement, but we'll also see it when we're dealing with certain emotions, pleasure, and our pain response here. So if this area starts to degenerate, then this person will usually have an onset of Parkinson's disease. So let me show you a couple of these structures that we talked about here. Wait a minute, let's do this. All right, so here's the substantia nigra, okay, pretty prominent. That's colored with the melanin. This is where we're producing our dopamine. Then just in front of that, the anterior portion, this is the cerebral peduncle. That's going to carry those descending motor tracts from the primary motor cortex. So that will be all the voluntary information that's going to affect your skeletal muscles. Then here you can see, again, it's tough to really see the medial lemniscus because it's made up of white matter. It looks almost the same as all the other white matter that's nearby. Right, again, this is where we get our ascending sensory information coming in. All right, now we're going to talk about the tectum, the tegmentum, and then our other structures here, the periaqueductal grain, all that fun stuff. All right, the tegmentum. This is going to be posterior or behind our substantia nigra. It's involved in postural motor control. Part of that, and we're going to talk about this here in a few minutes, has to do with the reticular formation. The reticular formation is this group of tissue that travels again throughout the brain stem, and it has a motor component and it has a sensory component to it. Well, the motor component primarily has to do with posture, muscle tone, that sort of thing. You'll notice in this picture here, we've got a little hole here. We talked about it briefly last lab class, right? That is our cerebral aqueduct. That's that little canal or passageway that connects the third ventricle to the fourth ventricle. Well, it's surrounded by the periaqueductal gray. And the periaqueductal gray, right, has to do with autonomic motor function. And it also has to do with emotional responses to intense stimuli. Right, so that's the periaqueductal gray will surround the cerebral aqueduct. We'll also see some of our cranial nerves, right, will have their nuclei in the midbrain, primarily cranial nerve 3, oculomotor, and cranial nerve 4, trochlea. Both of those have to do with movements of the eye. We'll learn about the cranial nerves more so in lab. And then finally, on the posterior portion of our midbrain is our tectum. Now, if I were to look at the back of your midbrain, I would see this structure here. That's called the tectal plate. So if I'm looking at it straight on, it won't be perfectly square, it'll be more rounded. There, it would look like this. You'd have this square with 4 bumps on it. Okay, square with 4 bumps. The top 2 are the superior colliculi. So these top 2 right over here. The bottom 2 are called the inferior colliculi, right over here. Right, the superior colliculi has to do with visual reflexes, and the inferior colliculi has to do with auditory reflexes. So I tell folks, when you're utilizing the superior colliculi, imagine yourself sitting there watching a tennis match or a volleyball match, and the ball is going back and forth. They're volleying, it's going back and forth over the net. So your eyes are following it. They're moving from the left and the right. They're moving together, right? Though, and then there's reflexes that undergo during that actual process of vision there. So those visual reflex and you tracking that ball utilizes the superior colliculi. The inferior colliculi is used in auditory reflexes. So if you were sitting and studying in the library, and I was to be approaching you and I'm saying your name softly because I don't want to get yelled at in the library. Hey, buddy, hey, buddy. And you turn to see who is calling your name, all right? You're utilizing the inferior colliculi. You're seeing where that sound is coming from. So here you can see, here's the tectum on the back portion, the posterior portion of your midbrain. All right, that's the midbrain. It's a fun area of the brainstem, but let's move on to the pons. Pons is another fun area. This is the middle portion of the brainstem. You'll see, if you're looking at the brainstem from the side, you'll see a bulge on the front. That's the pons. So the pons is similar to the midbrain in that it has sensory and motor tracts that are going to pass through it. Okay, sensory are ascending up to the cerebrum, and then motor is descending out to the periphery there. So we have a couple other structures here that we see in the pons. I remember when I told you each part of the brainstem connects to the cerebrum. So in the pons, we have the middle cerebellar peduncles. So again, they'll connect the pons to the cerebrum. Then we have the pontine respiratory center. And if you notice, it says here, it helps to regulate the skeletal muscles for breathing. Well, if you damage this center, you won't die, okay? It won't cause you the inability to breathe. What it does do is, when you damage this area here, you're not gonna have a smooth transition when you're taking breaths in and breaths out. So think of the pontine respiratory center and its effect of regulating the skeletal muscles. It just makes the breathing process a much more smoother process. Now you really can't see me, but it would sound something like this. I know it sounds weird, all right? But if you were to damage that area, you would lose that smoothness in the breathing. All right, then you have your superior olivary nuclei. Again, this is another area that helps with locating sounds. And then, of course, we'll have some of the nuclei of our cranial nerves located in the pons. Now, something I should mention to you about the cranial nerves is that cranial nerves can be either sensory only, motor only, or they can be both. All right, so some nerves just are for sensory only, some just do motor components, and then we can mix them up and have some nerves that do both of those functions there. So the cranial nerve nuclei that we see in this area are going to be cranial nerve 5, which is trigeminal, cranial nerve 6, which is abducens, cranial nerve 7, which is facial, and then cranial nerve 8, which is vestibular cochlear. So the nuclei for those cranial nerves are located in the pons here. So here you can see on our side view, here's that anterior bulge on our brainstem there. See it much better here. And then here's our middle, all right, cerebellar peduncles. This is what connects the pons to the cerebellum. So we slide on over here. All right, you can see some areas. Here are some of the motor nuclei for our cranial nerves. And then we'll see again the medial lemniscus located here in the pons. Again, it travels through all the different parts of the brainstem. Our superior olivary nuclei, which is important when we're dealing with sound localization. Again, calling your name, you turning to that area there. And then here you'll notice in the front, you have some fibers from what we call the pyramidal tract. And the pyramidal tract has to do with motor function, voluntary motor function. And then kind of surrounding that area here is the pontine respiratory center. And then off to the side and more in the posterior is where our middle cerebellar peduncle is located. All right, now let's get to my favorite part of the brainstem, the medulla oblongata. For such a small area, it does so much. It does so much, right? So it makes up the inferior portion of our brainstem. So inferior to the medulla oblongata is going to be our spinal cord. Again, in the medulla oblongata, we are going to see both sensory and motor tracts that are going to connect the brain and spinal cord to one another. We'll talk more about that in chapter 14. You'll see that in a little bit better detail there. So a couple structures that are important are the pyramids here. They sit on the front and they deal with motor control, specifically what we call cortical spinal tracts. Now these tracts originate up in the motor cortex, in the cerebral cortex, and they descend down to the spinal cord. So we call it the cortical spinal tract. Now, we learned last class how the right side of your brain controls the left side of your body and vice versa. That means that these tracts have to cross from one side of the body to the other side. Well, here in the medulla oblongata, we're going to see some, not all, but most of those tracts, right? The axons in those tracts are going to cross over from one side of the body to the other side of the body. So it can control the movement on the opposite side. So where they cross over, we call that the decussation of the pyramids. And if I can show you, here we go. Here are the pyramids right here in the front. Here and here. So there are these two anterior bulges that sit in the front. Then just lateral to that is a structure called the olive, and that's these other bulges here, which I'll talk about here in a moment. Here and here. All right, so the olives are going to contain the inferior olivary nucleus, which has to do with proprioceptive information being relayed to the cerebellum. In case you don't know what proprioception means, proprioceptive information is, first of all, your proprioceptors are the receptors that they're located in your joints, in the muscles, and in the tendons of those joints. And basically what they do is they provide feedback or information to your brain as to what your joint is doing. So if you close your eyes and I were to put all these strings on you, like a marionette or a puppet that you've seen, and I start to manipulate the movement of your extremities, right, your proprioceptors and those joints that I'm moving around with my strings are going to tell your brain what's happening. For example, if you're bending your knee, right, flexing the knee, the proprioceptors will send that information to your brain saying, hey, they are bending their knee at 35 degrees. Or if you are abducting your shoulder, right, bringing your arm out away from your body, those proprioceptors in and around your glenohumeral joint will send that information to your brain, telling your brain that your arm is being moved away from your body. So that's what proprioception does. And we'll talk more about it a little bit here when we get into the cerebellum here. And then, of course, we have our inferior cerebellar peduncles, which are going to connect, all right, the medulla oblongata to the cerebellum there. All right, when I was going over the different functions and characteristics of the brainstem, I did mention that you have some autonomic nervous system nuclei located in the brainstem. And so you have, all right, some important areas here in the medulla oblongata that house these autonomic nuclei. All right, so keep in mind that your autonomic nervous system undergoes, all right, a lot of processes that help to maintain your ability to live. Okay, the fact that these are things that you're not consciously aware of or you don't have to think about. Right? If I have an itch on my chin, I'm going to go scratch it. And so I have to think about moving my hand to do that. But you don't have to think about having your heart beat. It does it for you for a couple of different reasons, right? But the autonomic nuclei will help with that. Okay, so the first one there is the cardiac center. That regulates the heart's output. Now, when we talk about the heart's output, there's an equation for that. You'll learn that in Bio 211, excuse me. But basically, what cardiac output is how much blood your heart is pumping out. And that's influenced by how fast your heart is beating and how hard it's contracting, because it's a muscle, right? So if you need to increase the output, you can increase your heart rate or you can increase the force of contraction. If you want to decrease the output, you can decrease your heart rate or decrease the force of contraction. Okay, so that's what the cardiac center does. It controls your heart's output depending on what your needs are. The vasomotor center is going to influence blood pressure. So what it will do is it will increase or decrease the lumen or the diameter of blood vessels. So if you want to increase your blood pressure, then you can cause the blood vessels to constrict, and that creates more resistance. That increases blood pressure. If you want to decrease the blood pressure, right, you will cause vasodilation. Blood vessels will get bigger and blood can flow through easier, and you'll decrease the resistance. You'll learn of all the different things that can influence blood pressure. This is one of them, the blood vessel diameter. All right, the medullary respiratory center. This is the center in which allows you to breathe. All right, it controls your breathing rate, meaning it can increase your breathing or it can decrease your breathing. Normally, folks will breathe anywhere from 12 to 20 times a minute on average. Usually it's about 16 times a minute. Okay, so this the medullary respiratory center can increase or decrease that breathing rate. It can do so through these two groups here, the dorsal and ventral groups. Not to worry, you'll learn all about this fun stuff when you cover the respiration and 211. But what's important here is that the respiratory center here in the medulla oblongata communicates with the pontine respiratory center. So it allows for that nice smooth transition, all right, while you're breathing there. And if you look here at the bottom, you'll see that there's several other nuclei that are located in the medulla oblongata. Like the medulla oblongata, I feel like it's got it all. It's got so much stuff there, right? But it has, all right, nuclei for coughing, sneezing, vomiting, salivating, swallowing. All right, a lot of these processes, right, especially if we want to talk about certain reflexes, you want to get into the digestive reflexes, salivation occurs there. Some of these other reflexes here, coughing and sneezing, usually involve the respiratory centers. Maybe you inhaled something that, you've heard the term, oh, I swallowed something and it went down the wrong pipe, and you start to cough it up. Okay, well, here you'll see, all right, the medulla oblongata is responsible for several of these different types of reflexes here. We'll also see some of our cranial nerve nuclei located in the medulla oblongata. There's 12 pairs of cranial nerves. All right, so here in the medulla oblongata, we'll see the nuclei for the vestibular cochlear nerve, the glossopharyngeal nerve, which is cranial nerve number 9, vagus, one of my favorites, cranial nerve number 10, accessory is going to be cranial nerve 11, then hypoglossal will be cranial nerve 12. And then finally, and I only bring this up because we're going to talk about this in chapter 14, the nucleus cuneatus and the nucleus gracilis. All right, these two nuclei are going to receive somatic sensory information. What's that? That's sensory information that you can consciously perceive. Vibration, okay, temperature, touch, light touch, or what we call discriminative touch. All right, this information will travel, all right, to these nuclei in the medulla oblongata. Then they'll synapse, these neurons will synapse there in these nuclei, and then they'll ascend, all right, up to the cerebral cortex, and they'll travel through the medial lemniscus all the way up to the thalamus. Don't worry, we'll learn about that when we go over the different tracks in chapter 14. Okay, so that's the medulla oblongata. Here you can see a nice picture of it. Let me just do that. And then what I do want to show you is up here, you can see, and I love this picture because it's actually showing you, all right, some of these tracks here. So this track right here, the pyramidal track that you can see on the anterior portion here of the medulla oblongata, you'll notice these axons here, all right, a majority of them cross over. This is where we see that decussation, the crossing over of those axons from one side of the body to the other side of the body. Now, most will cross over. When they cross over, all right, they become part of the lateral, they become what we call the lateral cortical spinal tract. Then those that don't, and they stay on the same side, those are called the anterior cortical spinal tract. Not to worry, these axons will eventually cross over in the spinal cord. All right, so you have two places where you can cross over when we're dealing with the pyramidal system. They can cross over here at the decussation in the medulla oblongata, or they can cross over in the spinal cord. You're going to cross over one way or another. All right, here you can see a nice lateral view here of the medulla oblongata, and on the side here, right, you can see this is where we have our nucleus cuneatus and gracilis. That's for that somatosensory information as it ascends up the spinal cord. It'll enter into this structure, and those axons will synapse in there. Then you can see some of our respiratory centers here too. And then on the anterior portion, here are the pyramids, and then you can see, where's the pyramid on the front, and then you can see the inferior olivary nucleus there. And that's going to relay that proprioceptive information over there to the cerebellum. Speaking of the cerebellum, this is the last region of our brain. So it is the second largest area here. Sometimes it's referred to as the little brain. And so we saw how the cerebrum had folds in it. We called those gyri or gyrus for single. Well, in the cerebellum, we have folds too, but we don't call those gyri. We call those folia. right? Our cerebellum has a left and right cerebellar hemisphere, just like our cerebrum had, and it has a structure that sits in between those two hemispheres, and that's referred to as the vermis. Now, the vermis, all right, connects those two hemispheres to one another, but the vermis is going to receive ascending or sensory signals from the body, from the periphery there, regarding muscles of the torso and just overall balance sensation. Now, balance is a generalized term that we use that pretty much discusses proprioception and equilibrium. Okay, so there's three parts to the cerebellum. Right, again, this is similar. I know I keep drawing some similarities here between the cerebellum and the cerebrum, but we noticed how on the cerebrum, you had the gray matter on the outside. Well, the cerebellum, same thing. So we called that the cerebral cortex when we were talking about the cerebrum. Well, when we're talking about gray matter, well, in the cerebellum, that outer gray matter is called the cerebellar cortex. Deep to that is where the white matter is. Now, we refer to the white matter here in the cerebellum as the arbor vitae, the tree of life. And then scattered throughout our white matter, we'll have little pockets of gray matter, and those are our deep cerebellar nuclei. All right, this slide just shows you, all right, the cerebellar peduncles. Just keep in mind which one goes where. All right, the superior cerebellar peduncles will connect the midbrain to the cerebellum. The middle cerebellar peduncles will connect the pons to the cerebellum. And then finally, the inferior cerebellar peduncles will connect the medulla oblongata to the cerebellum. Each has its own little pathway in which these nerve axon tracts can travel from specific parts of your brainstem out to the cerebellum. So here's a nice picture, a lateral view and the superior view here of the cerebellum. And you'll notice here, right, we have our nice folds. Those are our folia here. Then we have the vermis in the center between our two cerebellar hemispheres. And so we have an anterior portion and a posterior portion. All right, posterior lobe back here and the anterior lobe up here are divided by a structure in which we call the primary fissure. So if you look here on our lateral view, our mid-sagittal view, you'll see how we've cut the cerebellum in half, and you can see the arbor vitae, the white matter on the inside, all right, covered by the gray matter on the outside. That's our cerebellar cortex there. Just to kind of give you something, a little bit of relation here, you can see, right, that the cerebellum sits right behind or posterior to the pons. And in between the cerebellum and the pons is our fourth ventricle. Here's the cerebral aqueduct that drains the cerebral spinal fluid down here into the fourth ventricle. All right, so what does the cerebellum do? The cerebellum is going to fine-tune movements. And I love this other fact that it also is going to store muscle memory. So last class, we talked about the primary motor cortex, and we talked about the visual cortex and the auditory cortex. And then we also talked about these structures, what we call association areas. So the primary motor cortex has an association area. We call that the premotor cortex. And it sits just in front of the primary motor cortex. It's anterior to the precentral gyrus there. And so the association areas usually will store memories of whatever it is that whatever cortex they're associated with. Well, motor function gets another storage site in the cerebellum. Okay, so now we can store memories up in the cerebral cortex, but now we can also store, all right, motor memories down in the cerebellum for those learned movements like playing the piano or the violin or juggling. All right, So think of the cerebellum. Yes, it's going to coordinate and fine-tune movements. It's going to make sure that your movements are going to follow the correct pattern, whatever it's supposed to be, right? Whatever skilled movement that you are trying to do, right? Whether or not you're trying to do something that requires a lot of dexterity. I know I keep playing the piano, right? Anything, a baseball pitch or jump shot, whatever, right? If you're trying to keep balance, on the curb as you're walking heel toe, right? You're going to require the cerebellum to help with that. And so it controls both, all right, voluntary and involuntary motor movements there. So what will happen is, if you think about it, your brain is constantly getting sensory information coming into it, and it's constantly putting out motor information, right, to do certain things, especially if you're walking, talking, and whatnot. So what we're going to see is, right, the cerebellum is going to make sure if you're doing these movement activities, it's going to make sure that those motions and movements are smooth. And so think about it like it's constantly providing biofeedback and kind of making small changes and tweaking certain things. And so what helps with that is when it gets proprioceptive information from your muscles and joints, so you can correct, right, any errors in movement that occur. This becomes very, very helpful when we're trying to help maintain your balance, all right, which requires maintaining equilibrium and posture there. So it's constantly getting that biofeedback, that sensory feedback, so we can actually coordinate certain motor movements there. Think of it like error correcting signals, right, between your premotor cortex, the primary motor cortex, and the cerebellum. So I love this picture here because it shows you all this stuff that happens. All right, so here you can see, right, voluntary movements being generated here by the cerebral cortex will travel down into the spinal cord and out to the specific muscles for whatever type of activity that you're doing. Now, some of that information gets sent to the cerebellum, just so the cerebellum has an idea as to what's going on. So the cerebellum will process that information and analyze it, and then it will send corrective information up to your motor cortex. Whereas it's constantly getting feedback here from your proprioceptors down in the skeletal muscles and joints. So it's getting that biofeedback and say, hey, you're leaning too far to the right. Oh, okay, no problem. Then it sends that corrective information up to the primary motor cortex saying, all right, you're leaning too far to the right. You need to lean back to the left. Okay, your body says, all right, I'm going to lean to the left. And it sends that information down to the skeletal muscles. All right, lean to the left more. And then, all right, the proprioceptors down there are saying, okay, you got it. And it sends that information back to the cerebellum. So my point being is you're getting this information. It's constantly being adjusted and fine-tuned until you get the desired results. So there's a process that goes on with this. So our second clinical view of the day talks about the effects of drugs and alcohol on the cerebellum. You may have watched a TV show or a movie in which a character is drinking and driving, and they're driving home, and the police officer pulls them over, asks them to step out of the car, asks the person, have you been drinking? They say no. They say, okay, I'm going to administer some tests, and I want you to perform these tests. All of the tests that these police officers administer when they're checking roadside sobriety are cerebellar function tests. When they have people walk the yellow line or the white line, heel toe, that's a cerebellar test. They'll ask you to close your eyes, bring your arms out to your sides, and then point your finger, bend your elbow, and touch your nose with your eyes closed. That's a cerebellar test. All right, so there's a whole bunch of them. All right, this is easier to demonstrate when I'm in the classroom. All right, but these tests in a person that has not been under the influence of any drugs or alcohol, they should do fine. Right? But if they are under the influence of alcohol, you may see that they are unable to walk the line. So they'll have gait disturbances. Right? You ask them to try to balance on one foot, okay? Stand on both your feet, pick one leg up, and just balance there. They might keep falling, to one side. Right? So it's really kind of, I jokingly said, drinking and driving, there's nothing funny about that, all right? But it's interesting to me that when the police officers do these roadside sobriety tests, they're actually administering to you free of charge, right, tests that you would have to pay several hundreds of dollars to see your doctor for. Okay, that concludes the parts of the brain. All right, so for the remainder of the class, I just want to talk about certain regions and areas of the brain. I want to talk about the limbic system. Right? I want to talk about higher order and cognitive functions. So let's start off with the emotional brain, the limbic system. All right, now the limbic system is made up of several different structures scattered throughout the cerebrum and also the diencephalon. And so these structures, right, are going to process how we experience emotions. So let's discuss a couple of these components here. We have our cingulate gyrus, the perihippocampal gyrus, and the hippocampus, and there's a couple other structures, but I'll start to go through it nice and slow here. All right, so the cingulate gyrus sits above the corpus callosum. So if I show you a picture here, you can see here's the cingulate gyrus. And again, a lot of these structures just help to connect multiple structures to one another throughout the diencephalon and the cerebrum. So there's the cingulate gyrus. You'll notice two other structures that we're going to talk about here in a moment. The perihippocampal gyrus, which is down here inferior to the diencephalon, and then the structure that sits on top of the perihippocampal gyrus, which is called the hippocampus. All right, so the I can't talk today. The perihippocampal gyrus, right, is going to be found in our temporal lobe. But what sits above it is called the hippocampus. And this is very important because we're going to talk more about this in a second. But the hippocampus has to do with forming long-term memories. If you lesion that structure, that hippocampal structure, right, you will lose the ability to create new long-term memories. Okay, short-term memories won't be affected, but long-term memories will. And so that hippocampus, right, sits right over here by the temporal lobe, right there. Don't damage that. Then we've got another structure called the amygdala or the amygdaloid body. This one here is important, all right, when we're dealing with emotion and our memories of emotion. Some of the primitive emotions like fear, for example, are really specific to this structure. If you were to lesion this structure, I wish I could remember. I keep saying this every time I give this lecture and I just keep forgetting. I need to go and look it up. But if you lesion this structure, there is a condition that you get in which you can have very, very outlandish reactions to certain mundane things that can evoke a very fearful response. And for whatever reason, folks that have lesioned this structure can also have very deviant, abnormal sexual behavior. And again, it's based on emotions and whatnot. If you notice here, the olfactory bulbs, tracts, and the olfactory cortex, obviously that has to do with smell. And so we found that these structures, since they're affiliated with the limbic system, right, it explains how certain smells and odors can provoke certain emotions. And I used the example of driving in a car before when we were talking about the habenular nuclei and how when you're driving along and you smell something and you remember that smell or it smells similar to like maybe a soup that grandma used to make when you were younger, and it can produce certain emotions, maybe a happy emotion or a sad emotion because grandma has passed away. All right, the fornix is just this material, all right, made up of white matter that is going to essentially connect the hippocampus with several other limbic structures there. So like I said, you can see all these purple structures here are various limbic structures that are just kind of scattered throughout. All right, the diencephalon and the cerebrum there. Oh, there's that reticular formation. All right, we talked about that when we were going over the brainstem there. I told you I'd come back and talk about it. Okay, first of all, the reticular formation is located in the brainstem and it's made up of gray matter. Gray matter is going to be cell bodies, dendrites, unmyelinated axons, and glial cells. All right. Glial cells aren't really going to be important when we're talking about the reticular formation. But anyways, the reticular formation has two components, a motor and a sensory component. I talked about the motor component back in chapter 10 when I was talking about muscle tone. And the motor component is going to help to regulate muscle tone. It also is going to help with specific autonomic functions, right, that we'll see in regards to some of our muscle movements, right, in our brainstem that will help transmit that information down to the spinal cord. Our sensory component, we call that the RAS, or the reticular activating system. This has to do with levels of alertness. So sensory information is going to ascend up into the brainstem there. And so what we'll see is the reticular activating system, all right, will help with that transmission up to the cerebral cortex. So this has to do with your level of alertness. All right, so for example, I am hoping that most of you, if not all of you, I should change that. I am hoping that all of you are at a high level of alertness right now. As I am talking, I am hoping that you are paying attention to everything I'm saying. So your level of alertness should be pretty high. So if I were to burst into your room and throw a snowball at you, you'd have a pretty good chance on seeing that, occur, and you could at least try to get out of the way. If the same thing were to happen, I was going to bust into your room and throw a snowball at you, but yet you were in a deep sleep, all right, your level of alertness is way lower. Okay, so the reticular activating system helps to bring about, all right, our general awareness, what's going on, okay, what's happening, like when we're moving, certain sensations, all right, even conscious thoughts. So here you can see the reticular activating system in our reticular formation. So the reticular activating system is going to coordinate certain sensory information, comes from, for example, auditory information or visual or even some touch information. That sensory information is coming up from the spinal cord and from other sensory receptors. And the reticular activating system will then help to transmit it, all right, to the appropriate area of the cerebral cortex. If this structure is not relaying or allowing that sensory information to move, all right, and transition up into the cerebral cortex, you might not be aware of certain things. So that has to do with your level of alertness there. Then also, all right, our motor output from the reticular formation, you can see it descending down here into the spinal cord there. Which brings me to our third clinical view of the day, all right, our states of unconsciousness. All right, so there's several different states of unconsciousness here. The first one, fainting, requires, all right, that is a brief loss of consciousness. And so most times it's because you're not getting enough blood to your brain. And that could be for several reasons. You could have a blockage, you could have a hemorrhage, or you could have really low blood pressure. Stupor, right? You'll see this in MMA fights, boxing matches quite a bit when someone takes a beating to the head, right? Some sort of brain trauma, okay? And so people will use the term, oh man, that guy looks like he's out of it. Right? And what will happen is, right, they've taken, well, in that case, such a beating to the brain, right? The only way that you can get these people to come back to some sort of normal consciousness is with some sort of extreme stimuli, like smelling salts that you've seen in movies. They'll hold something under somebody's nose and they'll come out of it like, oh, okay. Or someone gets slapped in the face. But usually they'll come out of this state of stupor with some sort of extreme stimuli. All right, what can cause this? Severe metabolic disorders that can affect the liver or kidney. All right, a lot of times, drug use. People I won't say overdose on a drug because that usually implies that they're dead or they're in a really bad state. But if they take too much of a certain drug, right, it can put them in this state of stupor. All right, coma. Anybody that's seen a good soap opera knows what I'm talking about because there's always somebody in a storyline somewhere in a soap opera that's in a state of coma and then they come out of it. In this case, all right, it's like a really deep state of sleep, all right, deep and profound unconsciousness. These folks are unresponsive. You'll have people, you could have someone in the room yelling at this person that's in a coma, slapping them, all right, that won't bring them out of it. Again, this can be caused by head injury, metabolic disorders, stroke, low blood sugar. You've heard of diabetic coma, all right, when their blood sugar drops significantly and then they fall into a coma. And again, of course, drugs. Now, you can also have a medically induced coma, and sometimes the physicians need to put somebody in a medically induced coma, right, to help save their lives. And then last but not least is the persistent vegetative state. This is the term in which you hear most people will say, oh, that person's brain dead, right? They will not have conscious thought and they are not aware of anything, right? Vital brain functions will continue on, right? But cognitive brain functions cease. So every once in a while, these type of people, you'll hear family members say, there's still a chance to save this person. I just saw their finger move. Yeah, that'll happen because sometimes you'll get a spontaneous discharge of an action potential through some of the neurons there, which will trigger the movement of skeletal muscle. But trust me, these folks, all right, do not have any type of cognitive brain function. So therefore, the person that you once knew, and again, I always believe in miracles too, but the person that you once knew is no longer with us. Speaking of cognition and cognitive function, that leads me into what we call higher order mental functions. Kind of a swinging, taking a circle back here to the frontal lobe and a lot of what the frontal lobe does and several other areas of the cerebrum. All right, but I do want to talk about higher order brain functions and throw a couple other functions at you so you're pretty clear on what that is. When we're talking about higher order mental functions, we're talking about the process of learning, the process of actually creating and making memories, and then reasoning, critical reasoning, that sort of thing. This occurs in the cerebrum, but specifically in the cortex of the cerebrum. Right? It can involve multiple areas. Right? In some cases, it involves just one, but it can involve multiple regions of the brain there. Right? So both conscious and unconscious processes will occur here. Sleep is a wonderful, how do I want to say this? Phenomena. Okay. I wish I didn't have to sleep because there's a lot of stuff that I want to be doing, but it is a natural process of being a human. All right. And so I have to sleep. Okay. So sleep is when we have that absence of consciousness. So think of things just kind of shutting down. We're taking your brain offline. So vital functions will continue to occur, but a lot of those higher order brain functions won't. Right? When we're talking about reasoning or decision making, well, you're sleeping, so you really shouldn't be doing any of that. So what we do is we hook you up to what we call an EEG, and we will monitor, all right, these wavelengths that occur, right, during your sleep period. And we break sleep down into two stages. We have non-REM sleep and then REM. So what is REM? REM is what we call rapid eye movement. When you're in the stage of REM sleep, your brain is quite active. And it gets the name because, all right, your eyelids are closed, but you can see underneath the eyelids the movement of your eyes, back and forth, back and forth. So we call it the rapid eye movement. All right. You spend a very short period of time in REM sleep, only a quarter of your sleep time, 25%. All right. So for those of you that can remember your dreams, then that means you've had a pretty fair share of REM sleep. Those of us that can't remember our dreams, you're not getting enough REM sleep, but as you get older, that starts to decline anyway. But the important thing about the REM period is this last point here. This is where you consolidate memories. Now, I'll talk about this in a moment because we're going to talk about memories and memory formation. All right. So think of this period as when you're sleeping, you're in REM sleep, your brain is consolidating memories. So when it's time for you to retrieve those memories, it's much easier for you to do that. This is largely important. And that's why folks like myself and other teachers always encourage their students to get good sleep, because you're learning all this information, but it won't do you any good if we can't push that information from short term to long term. And that's where this happens. I'll explain that here in a few moments. The non-REM sleep, this is where you spend the majority of your time. All right. But this is where you kind of recharge. You know how you charge when you go to bed, you put your cell phone on the charger? Well, here's what non-REM sleep does. It's putting your body on the charger. This is where you'll do your growing when you're in adolescence. All right. If you've depleted your energy reserves, no problem. This is where we're going to restore those energy reserves. All right. Also, because you're sleeping and not really doing anything, you're going to be conserving a lot of that energy for just the basic maintenance functions that your cells and tissues have to undergo. So it's really nice, really, really nice. All right, so one of my favorite statements, if you are a baby, which none of you are, you require about 17 to 18 hours of sleep a day. If you're a teenager, you need about 8.5 to 9.5 hours. Still debatable. And then as an adult, 7 to 8 hours. I took an exercise physiology class when I was in college, and my professor said that Olympic athletes require 8 hours of sleep. I worked with a physical trainer, and they told me that I needed to get 8 to 9 hours of sleep. Point being, most adults will require about 8 hours of sleep. As you get a little bit older, right, into your golden or twilight years, that number will drop down a little bit. We all know that sleep, that lack of sleep is unhealthy. Okay, you need sleep. If you're not getting enough, you can start to mess with your mental functions. Long term, we can get depression. We get that poor memory. Well, why is that? Because you're not getting this. You're not getting the REM sleep. If you're lacking in sleep, you're not getting the REM sleep. You're not consolidating memories, in which you need to do that. And of course, now more than ever, especially with COVID, right? People can get vaccinated all they want, which is great. That will significantly reduce your chances of hospitalization and death. But, all right, if your immune system is doing garbage because you're not sleeping, you're increasing your chances of getting infected. That means you're increasing the chances of spreading it. So, what is insomnia? That is when you have difficulty falling asleep or staying asleep. We see this quite a bit as we get older, partially because, of profession, being a parent, being in a relationship, or not being in a relationship. We just find that as people get older, they're more prone to insomnia. Now, every time I do a medical DOT exam for truck drivers, one of the things I ask them is, have you ever been diagnosed with sleep apnea or some sort of sleep disorder. Sleep apnea is a very serious condition, right? It impacts your ability to get a good quality sleep. But what happens is in sleep apnea, you start to have breathing interruptions. I read an article. The author of the article said that when they were a little kid, they had to go 1 year and visit grandma, and they slept in the same room with grandma. Grandma was a little bit overweight. Grandma would fall asleep first and used to freak the author of the article out because the author would lay there in bed and count, all right, to see how long it would take for grandma to breathe again when she was sleeping. And she said some of her counts got up to 30 to 40 seconds. That's a long time. So these breathing interruptions are not good. Some folks will wake up frequently because when they stop to breathe, that causes them to wake up. Some might not, all right? But when it's a long period of time, that's an issue. Snoring is usually an early indicator of sleep apnea. So how do we treat it? We put this contraption, not really a contraption, but we put a mask on these folks called the CPAP. Stands for continuous positive airway pressure. And basically it forces air into your respiratory system, helps to keep, all right, air entering into your lungs so you can breathe. And folks that address that get get a CPAP, they notice that their sleep quality drastically improves. All right, so you heard me talking about cognition earlier, right, when we were talking about the persistive vegetative state there. So in case you weren't sure what cognition is, it's these mental processes that involve awareness, knowledge, memory, perception, and thinking. And so that includes all the primary cortex areas and their association areas as well. And so we've seen, all right, when we've talked about cognition, we have a pretty decent idea where certain parts of cognition or the actual physical locations of certain cognitive mental processes are located within your cerebrum. And we've done studies to do this, and there's been stories and experiments that have helped us. For example, if you've ever heard of the case of Phineas Gage, if you've ever taken a psychology class, this person is quite familiar to you. We know that the frontal lobe of the cerebrum has to do with personality, decision-making, planning, cognitive thinking, all right, knowledge. All right, so all these different qualities are in the frontal lobe. Well, what happens if we damage, all right, the frontal lobe, specifically certain areas there? Well, unfortunately, with Phineas Gage, he learned the hard way. The guy was a really nice guy. He worked on the railroads back in the late 1800s. And unfortunately, he had a bad accident with dynamite, and it shot a metal spike, all right, up through underneath his left eye, and it exited somewhere out of the top of his head. It tore through part of his frontal lobe. Well, after that accident, now he lived, thank goodness, but after that accident, his personality changed dramatically. He would lose his temper. He would become abusive with people, and his whole demeanor could change at the drop of a hat. So we see, all right, through these studies and these stories, how, all right, these certain areas of the brain can explain what happens when you damage them, how that will impact normal functioning of those areas there. So we have a term here called agnosia, and that's when you lose the ability, right, to recognize or even to understand what a stimulus is. So for example, we can use our speech agnosia if you damage your Wernicke's area, which is usually in the left hemisphere, back towards the parietal lobe, if you damage your Wernicke's area, you will then lose the ability to recognize, all right, the meaning of sounds or words. It impacts your speech sound comprehension. So let me get into memory here real quick. Nope. No. Let's stop here.